question six is scenario of a patient with COVID-19 infection. And the questions are, what is malignant arrhythmia? Give examples of one atrial malignant arrhythmia and two ventricular malignant arrhythmias. How will COVID-19 infection lead to malignant arrhythmia? Then mention things that can lead to malignant arrhythmia: peri-op, pre-op, and intra-op. And then any other question? If a patient is on ionotrop and develops malignant arrhythmia, what will be advised to the surgeon? And okay. So the first question, what is malignant arrhythmias? So malignant arrhythmias are life-threatening arrhythmias that result in cardiovascular collapse. Yeah, that's hemodynamic instability or sudden cardiac arrest or death. These are malignant arrhythmias. While some arrhythmias are benign, you can have malignant arrhythmias that are life-threatening and can lead to sudden cardiac arrest or death, or maybe just cardiovascular collapse. So for examples of malignant arrhythmias, for atrial malignant arrhythmias, you have atrial fibrillation with hemodynamic instability. While for ventricular arrhythmias, you have ventricular tachycardia, you have ventricular fibrillation, and you have torsade de pointe. These are malignant ventricular arrhythmias that are life-threatening. So how will COVID-19 induce malignant arrhythmias? We know COVID-19 is a multi-systemic infection. So even all parts of the heart can also be affected. The muscles of the heart. So COVID-19 can result in myocarditis. It can also cause pericarditis and even endocarditis. So by so doing, with inflammation of these parts of the heart, COVID-19 can predispose to development of arrhythmias. And when there's infection of these parts of the heart, the mechanisms by which COVID-19 causes malignant arrhythmias is that we know that there's a cytokine storm in COVID-19. So this cytokine storm will induce severe inflammation these organs when it affects these organs. Even the blood vessels of the leading to the heart may be affected. Coronary arteries too may be affected. Therefore, patients could also have hypoxic injury resulting from endothelial injury. So sometimes even the cytokine storm can even induce coronary vasospasm that can lead to hypoxic injury to the heart, direct effect of the virus on the heart. All these factors in COVID-19 can lead to development of malignant arrhythmias like ventricular tachycardia and ventricular fibrillation in patients with COVID-19. And in several studies done during the COVID-19 period of patients who died from COVID-19 and patients who survived from COVID-19, it was found that most of the patients who died from COVID-19 were patients that developed malignant arrhythmias with COVID. Those are the ones that there was increased mortality. So the next question is, what are things that can lead to malignant arrhythmias? Peri-op, pre-op, and intra-op. So for surgery, most of the time you find out that patients are taken for surgery. And if patients do not have a proper cardiovascular assessment before surgery, patients develop cardiac arrest on the table. So what are the factors peri-op that can lead to development of malignant arrhythmias? Age, patients that are elderly, so patients who have myocardial disease, if patients have a pre-existing cardiomyopathy, they have a DCM, they have hypertrophic cardiomyopathy, they have an alcoholic cardiomyopathy, peripartum cardiomyopathy, whatever form of cardiomyopathy. If this is not properly handled before surgery, this can put patients at risk of a malignant arrhythmia. So in fact, any structural heart disease, hypertensive heart disease, any form of structural heart disease prior to surgery, without patient optimization, and sometimes even with optimization, the stress of surgery can now trigger arrhythmias in these patients. Even then, arrhythmogenic conditions, patients could have Wolff-Parkinson-White syndrome. That was if a proper evaluation was not done, this was not detected prior to surgery, or maybe sometimes even with evaluation, patients with Wolff-Parkinson-White syndrome, with the stress of surgery, we know that it can trigger supraventricular arrhythmias while patient is on surgery. And then even patients with channelopathies, patients with long QT syndrome, patients with catecholaminergic polymorphic ventricular tachycardia, Brugada syndrome, long QT syndrome, all these channelopathies that are pre-existing in the patient can, predispose patient to development of a malignant arrhythmia. Am I audible?
Yes, you are.
Okay. Then, if patients have coronary artery disease, patients have ischemic heart disease, it can predispose them to development of malignant arrhythmias. Also, if patients have left ventricular dysfunction, usually those with ejection fraction less than 40%, is also a pro-arrhythmic condition. And then another important thing is electrolyte derangements. Prior to surgery, if patients, they have hypokalemia, hyperkalemia, hyponatremia, hypernatremia, hypomagnesemia, hypocalcemia, all these electrolyte derangements are pro-arrhythmic, and can develop and can predispose patients to development of arrhythmias, prior to surgery. So intra-op, what are the things that can predispose patients to surgery intra-op? Majorly is administration of anesthetic medications that have an effect on the heart, especially those drugs that prolong the QT interval. So they can lead to development of malignant arrhythmias when patient is on the operating table. Examples of this medication are anesthetic medications, are inhalational anesthetics, and drugs like propofol are things that can predispose patients to, develop arrhythmia.
I don't know if I'm the only one. I can't hear you well.
Ionotropes. If patient is on ionotropes and patient develop malignant arrhythmias during the surgery, my advice. Hello? Am I audible?
Your
network
line
was
is fluctuating. It's fluctuating.
It's breaking. It's
It's
fluctuating.
breaking. Okay, but you're better now. You can continue. You're better now.
Okay. So, if patient is on ionotropes and patient develop a malignant arrhythmia on the table, of course, my advice to the surgeon at that point in time will be to stop the surgery, and then we commence the advanced cardiac life support protocol. So it's for us to commence CPRO immediately for that patient, and while CPRO has been commenced, CPR is going on, patient is being ventilated, is to get a defibrillator and then record exactly which rhythm that patient is having. So that if patient is having a malignant rhythm like a VT or a ventricular fibrillation, which are shockable rhythms, we can shock the patient immediately and resuscitate the patient. And after doing that, we want to review the anesthetic medication that is being used in this surgery, if they have any and in the inducement of these arrhythmias. We also want to ensure good pain control for this patient that has developed malignant arrhythmia during surgery. And thereafter, if it's not an emergency surgery, it will be better to stop the surgery and then to evaluate these patients to see whether patient has any pro-arrhythmic condition. We may even need to invite the electrophysiologist also to evaluate this patient to find out what may have induced this arrhythmia during surgery, and then handle this before patient is reconsidered for surgery, especially when it's not an emergency surgery, that is needed to save the patient's life at that moment. Surgery can be stopped and postponed until the patient is resuscitated and then thereafter evaluated before recommencement of surgery. Thank you.
Okay, thank you. You had just 11 seconds left, so you did well. All right, so thank you so much, Dr. Brown, for taking your presentation. So the floor is open to questions and contributions. Okay, so in the absence of questions and contributions from the participants, maybe we'll call on our chiefs, Chief Adeyanju and Chief Orimolade. Thank you.
Okay, thank you, everyone. Thank you for the presentation. Thank you, Dr. Florence. While I was reading for my own exam, I came across, I don't know how many of us are on Medscape. If you're on Medscape, I felt Prof brought out this question it was during COVID, and there was a report on Medscape where they created different clinical scenarios, 1, 2, 3, and 4. So you can just type malignant arrhythmia and cardiac arrest. To various electrolytes, to various clinical scenarios, and how you manage those clinical scenarios. So I think that's what I would say about that question. You see that like 4 clinical scenarios there. I wouldn't know which of them was painted for them, really. But just type malignant arrhythmia and cardiac arrest in the operating room, Medscape. Then you'll be able to see the management and also the case scenarios.
Yes.
Can you? Hello?
Yeah, okay. I've actually seen one. Yeah, yes,
No,
you're audible. So I've seen one. Should I read through?
You will see the marriage. You have to individuals. You have to go and read it. It's quite a lot.
It's very long.
You see, yes, it's long, but you see, there's a place for management where all those electrolytes and everything are there, and what you will do on the table in case you see arrest on the table. So it will be easier to just go through those. They wrote example 1, example 2, example 3, example 4. So I felt it was one of those clinical scenarios that was brought out for exam. That was my own assumption when I was reading. So I came across it when I was preparing. Do you understand? So I wish if you have time to, so that in case any of those scenarios that came out, and it was during COVID, you understand? So it's just like clinical scenarios. So that was what I used when I was reading for this particular question. So I don't know if that helps. Thank you.
Yeah, thank you, Chief. Thank you. All right. Okay, I've shared the stuff to the page. Maybe you just click on the link and then it takes you there on our page. All right, okay. Chief Adeyanju. Thank you so much, Chief Allison. Chief Adeyanju. Okay.
Yes, please. I think that it has been well discussed. That's what I will say. I think it has been well discussed, and Dr. Orimolade has already mentioned what we should check up. Please, let's check them up. Thank you. And it's good the way that it has been itemized, peri, pre, and post, intra and post. Then we should remember that we need to follow up after the surgery. Thank you.
All right. Thank you. Thank you so much, Chief. Okay, so somebody's asking that COVID-19 and what we type, ma. Sorry, there. Dr. Rabbi, I don't understand what you wrote down here.
Okay, asking for what I said, malignant arrhythmia and cardiac arrest in the operating room.
Okay.
Yes, so malignant arrhythmia and cardiac arrest. So it will tell you pre, post, peri, everything you see, and now put clinical scenarios to them.
Okay. Okay. Thank you so much. All right, so we'll move over to the next presenter. Thank you, Dr. Brown, for your presentation. So the next person on the list is Dr. Onyebuisi, going over to October 2022, number one.
Hello?
Yes, Chief. Okay, we're waiting for Dr. Conte to put up the question paper, October 2022. You have to take number one.
Okay. Okay.
Okay. Are you ready now, sister? Are you ready now, sister? Very nice, sister.
Dr. Rabo, please, you share with us just, okay, that the YouTube video for the VSC, please just share with us on that page so that we don't forget.
All right,
You know,
no problem.
we have a lot of things on our minds right now, so that we don't forget. If you can see the ASD, so please just share the embryology as in the defects. Okay, Dr. Conte. Dr. Sorry.
Sorry, I have to look for the paper. I think what I'm sharing is, excuse me. If someone has access to it, they can share it. Let me check. I have to. I thought it was April 2022. Let me see, it's October.
No, okay, that particular one was actually handwritten. That was handwritten, I think. Wait, let me confirm. That one is handwritten. Yeah, that one is handwritten. So what I'm going to do now is that I'm copying it to paste it on the chat room. So we'll read through that from the chat room. Okay. So Dr. Nyebo is okay, it's on the chat room now. In question.
Okay. Please, Florence, forward it to my WhatsApp. Let me just I'm struggling going back to find it. Just forward it to me.
Okay. All right, that's fine. Okay, so Dr. Nyebo, you actually have the floor. You know, we're working with time. You know? Yeah, thank you.
Okay. Okay, thank you. Can you hear me well now? Hello, can you hear me?
Not
Hello?
really. You're okay. We can
Okay,
hear you when you say, "Can you hear me?" Oh, the network is bad.
Let me switch to this. Let me switch to another.
Okay, well, okay. While you're trying to sort yourself out, can some other person present? Then you present after the person.
Can you hear me now?
When you say, "Can you hear me?" I hear you, but when you now talk like a continuous statement, I don't hear you again.
Okay. Let me. Well, I've seen the question. The question reads: discuss through non-rheumatic valvular heart disease. All right, non-rheumatic valvular heart disease encompasses a range of other valvular heart abnormalities that are not associated with rheumatic fever. And if we look at the range of valvular heart diseases that are not associated with rheumatic fever, we'll be able to group them according to the valves they affect. And if we look at the valves they could affect the pulmonary valve, and at pulmonary valve, they will be able to cause a pulmonary stenosis. They will be able to cause pulmonary regurgitation. They can affect the aortic valve and cause aortic regurgitation, mitral valve, mitral stenomitral regurgitation, and the same thing with tricuspid valve. We can also classify them according to the nature of manifestation that they create, which can either be a stenosis or a regurgitation. We can also group them according to their etiological predisposition, in which case we'll be able to say that these conditions are coming from a degenerative valvular heart disease and ischemic, a degenerative calcific valvular heart disease and ischemic valvular heart disease, and endomyocarditis, as well as radiation valvular heart diseases. Now, we can also have congenital abnormalities. So when we look at their etiology, they are commonly caused by degenerative calcific changes. They can also be caused by congenital abnormalities, and then they can be caused by endocarditis, ischemic heart changes, and then radiation exposure. In terms of pathophysiology, the non-rheumatic valvular heart diseases will cause a regurgitation or a stenosis at the heart, where they will be able to cause a narrowing, impair the flow of blood through the valves, or cause a backward flow of blood into the cardiac chambers. And these non-rheumatic valvular heart diseases can manifest with symptoms such as shortness of breath, fatigue, angina, syncope, and palpitations. And then clinically on examination, they would also be able to cause symptoms that are related to heart failure, in which case we'll be able to see symptoms of fluid retention, peripheral edema, pulmonary rales, jugular venous pulsation elevation, and heart murmurs. And depending on the valves that are affected, there are different manifestations of the murmurs that they will be able to create. For instance, if you have a calcific, degenerative calcific aortic valve disease causing aortic stenosis, we'll be expecting a soft blowing murmur, a soft blowing murmur in diastole that is had maximally at the second right intercostal space and may be able to radiate to the neck. And such a murmur will also have an ejection click. If is a stenosis murmur, oh sorry, that was for stenosis murmur. If it's if a stenosis murmur, aortic stenosis murmur will give us a crescendo decrescendo murmur that is heard best at the second intercostal space, right sternal border, and may be able to radiate to the neck. And then if it is a regurgitant murmur, we'll have a soft blowing murmur in diastole that is heard best at the left sternal border. And it can also cause a murmur at the mitral area and tricuspid area if the mitral and tricuspid valves are affected. In terms of investigations, echocardiography is the gold standard for diagnosis of non-rheumatic valvular heart diseases. And the echocardiography will be able to help us assess the valve anatomy, the valve functions, and then the heart chambers. Using echocardiography in these patients will be able to also do a chamber assessment, and some of the valvular heart diseases may be presenting with chamber dilatations. They may also have a left ventricular end diastolic pressure or increased left ventricular end diastolic volume. Cardiac MRI may also be used for a detailed evaluation of the ventricular functions, as well as cardiac CT scan can also be done to assess the calcifications, especially with respect to aortic stenosis. We may also do a cardiac catheterization to enable us to assess hemodynamic measurements in severe cases. In managing these patients with non-rheumatic valvular heart diseases, principally depends on the presentation that this patient comes in with. If, most of them use our 4 pillars of heart failure management, optimize it, and ensure that a patient has also diuretics to enable us manage, relieve the symptoms of congestion and fluid retention in this patient. Beta blockers are also used in this. AC inhibitors or ANI or ARBs are also useful in this patient when they are presenting with heart failure to reduce the preload and then the afterload in these patients. Now, anticoagulation is also important in this patient if they're presenting with heart failure, because with dilatation that may be available in the heart, and then assuming is also endocarditis related valvular heart disease, they are predisposed to intracardiac thrombus, and such patients will also benefit from non-vitamin K dependent anticoagulants. That's the NOACs, because they are not rheumatic valvular heart diseases. And if these patients have actually been optimized on these medical therapies and then they are not improving, surgical options may also be available to manage these patients. And these patients could benefit from aortic valve replacement if they have aortic stenosis problem. They could also benefit from transcutaneous aortic valve replacement also, or surgical aortic valve replacement. If the mitral valve is involved, mitral valve repair or replacement in cases of severe mitral valve is indicated. It's also important that in managing these patients and in assessing these patients, we can also use the severity of involvement of the valves or severity of affectation of the valves to also classify them into mild, moderate, and severe. And for aortic valve stenosis, if the mitral valve area, if the aortic valve area is less than 1.5 cm squared, and then the pressure gradient is less than 20, and then the jet velocity is less than 2.5, such a patient is mild aortic valve. If the aortic valve area is between 1.5 to is between 1 to 1.5, and then the pressure gradient is between 20 to 40, and the jet velocity is between 2.5 to 3.5. That brings them into moderate aortic valve involvement. And then if it is the aortic valve area is less than 1, and then the pressure gradient is more than 40, and the jet velocity is more than 2.5, that also shows is a severe aortic valve area that should actually go for surgical intervention. Some of the complications these patients may present with include heart failure, arrhythmia, and some of these arrhythmias could be supraventricular arrhythmia, atrial fibrillation, atrial flutter, malignant arrhythmias has already been mentioned, including ventricular tachycardia, ventricular fibrillation. They may also present with that. These patients must also present with stroke in case there is an intracardiac thrombus that was embolized and goes to the brain. They can present with thrombus. Infective endocarditis is also another complication that this patient will present, and then sudden cardiac death.
Okay, thank you so much. Yeah,
Do I
that's
still
true.
have time?
No, you've elapsed the time, but I'm just allowing everyone to just present so that we can get as much as we can. But you actually took 10 minutes and then 20 seconds. So you were quite on time. Do you have any more things to say? Do you have more things to say? All right.
Yeah, well, in terms of prognosis, it depends on the timely intervention. If they are untreated, the non-rheumatic valvular heart diseases such as aortic stenosis can lead to a high risk of mortality. And if these patients are presenting with heart failure within 2 years, possibly such patients will not be able to survive. And then if they're presenting with syncope, within 3 years, they will not be able to survive. And if they're presenting with angina, within 5 years, they will not be able to survive. So it's important that these patients are timely evaluated and then optimized medical therapy. And then when they're also not doing well on medical therapy, we go for surgical interventions.
All right. Thank you so much, Dr. John, for taking your part. Thank you so much. Okay, so the floor is open to questions and contributions.
Thank you, Chief. Thank you, Chief. Hello.
Hello, I can hear you.
Yeah. Just a quick one on the classification for the moderate AS. The jet velocity is 3 to 4 cm per meter square, and the severe is greater than 4. Everything in severe is 4 as for except the area, which is I think less than 1 cm square. So for the moderate,
Okay, thank
it's 3
you.
to 4. But for the severe, is greater than or equal to greater than or equal to 4 cm per second. And then for the under the etiology, you must not forget the rheumatic cause, the rheumatoid disease. Patient with rheumatic arthritis, they could have it cause an AR. They could also have also an AS, ditto ankylosing spondylosis. All those connective tissues, they could have associated valvular affectation. And then some syndromes too, especially in the congenital aspect. The Williams syndrome too can be affected with the aortic stenosis. It's also very important not to. And then also part of the connective tissue patient with Marfan's, they could have an AR in addition to the aortic neurism, Ehlers-Danlos. So we could also look out for other physical features in them too. And then
Yes, you're very correct. Well, first, let's pick it. This is in the process of classification that we will be able to forget all of this. First of all, we can classify them according to the valves that are fed. We can classify them etiologically, and we can classify them. And then when we now classify them according to either congenital or acquired, that's where we'll be able to remember all this under the acquired causes.
Yes. Under the acquired, must not forget the ischemic cardiomyopathy for patient with MR, which can be either acute or chronic. As a case of a patient with myocardial infarction, we could have an acute MR. Of course, over time too, they could also have a chronic MR. And the management, of course, will be different. The presentation, they are likely to have acute pulmonary edema in the case of acute MR. So I think we should just do that. Thank you.
Thank you so much. Okay, yeah. Thanks so much, Dr. Ayodeji, for your input. Okay, so somebody
I want
wants
to
to say
understand
something.
something. When this question, is it all the valves we're supposed to talk about? The aortic, the mitral, the pulmonic, all the valves? Then the tricuspid. Then when
Yes,
we
yes.
are, for aortic, we have stenosis, regurgitation. For mitral, stenosis, regurgitation. Then we now have prolapse. Then for pulmonary, the same thing like that. You understand where I'm going to? Because this question is actually very long. If you're looking at the way, it's like a whole textbook. Looking at
It,
where you are
But
it,
you
going.
know, they are asking for non-rheumatic. So you start with
Yes,
the
ma'am.
etiology and classification, and you pick them. So
Okay,
it
ma'am.
can affect it either way. Just like in rheumatic can be either MR or MS. So if you pick it the way they are saying it, the earlier discussants, if you pick it the way they have said it, using the etiology aside rheumatic, then you have a lot of things to say. So if you are talking of ischemic now, it's difficult to start mentioning stenosis with ischemic. Do you get?
Yes. Yes.
So yeah, so you pick the etiology, I get the etiology. When you pick ischemic and you tell us where can you want ischemic normally affect is what? Do you understand? That's when you mention is majorly either the anterior mitral valve, posterior mitral valve. You tell us the arterial supply in that instance. That's what they want to be hearing, not just mentioning it. Do you get? So you mention if you are mentioning connect the one from connective tissue diseases, then you now mention it can be aortic in case of this connective tissue disease, blah blah blah. That's what they want to hear. And it can also be associated with aneurysm. You understand? That's for AR. Then if you are saying MR or mitral valve affectation, then you now pick the ones that affect the mitral valve, the Sjogren's, the SLE, you understand, to mention it, and the Marfan's, as the case may be, too, can also affect. You now see when you now have Mixed-Masse's conversion or after a chronic this thing, you can now have some thickening and blah, 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 which in some instances might present with stenosis or not. You mention it like that. You even go to the ones that are caused by maybe like tumors, for instance, that we now mimic, you understand, like a tumor plug. You mention the tumors that you can see on the valves that will also affect the valves. You mention that's the way you'll be saying it. Before, if you now get to tricuspid, the one that is non rheumatic for tricuspid, commoner one is what the atresia. You mention it. That's the way you be before you say all these things. You would have gone so far. And as you are mentioning it, you are telling us the particular valves that are affected in those etiology. That's the way you will pick it. If you keep talking like that, you are not stopped or you still have time. Then you go on to management the way you have said it. The ones you can use balloon, this thing you mentioned, the one you can use this one you mentioned. You can even go as far as saying this is natural history with valvular. You can move your stuff that you have to mention. The patient has Marfan, for instance, now you mention. So the treatment will depend on the cause. So you have gamut of things to say. You just keep talking till you are stopped. If they don't stop you until you even get to surgery, you continue. But make sure you start well and classify it well. Then you go step by step by step by step to management and prognosis, as the case may be. So when you see any questions like that, even if you meet it in exam and you are sounding confused, just calm down. When you calm down, just say, okay, they've given you this presentation. How will you start? You start from the definition now. You start from the epidemiology. You start from the etiopathogen. And that's the way you will go to an exam anytime you are stuck. And you keep talking like that till you get to conclusion, just like you are presenting a case. And you try as much as possible to bring out all those thoughts you gathered within the space of 10 minutes. Just keep talking and keep talking and keep talking. You always find something to say. Sorry that I had to cut you in that way.
Thank you so much, Chief.
Then sorry, I forgot. For the TS and the PS, we can talk about the carcinoid
Syndrome,
disease
yeah.
syndrome, as affecting for the TS and the PS.
Atrial myxoma is also there for the left side. You also will mimic mitral stenosis. So you just keep saying everything you know. There's no stuff that is hidden there. You'll be surprised at what you will say that will impress someone and they will just dash you mark. You get.
All right, thank you, Chief. I don't know if we have any other contributions. Chief Adeyanju. Okay, thank you.
Yes, thank you. Thank you, Chief Oyewuze, for that excellent discussion. Yes, it has been said how you should go about it. I'm not sure whether I heard degenerative valvular heart disease because they're also part of it. So if you can also get there, you mentioned them. Like Dr. Ayodele said, don't forget this, put the syndromes there from your congenital, all these things, just outline, you'll have something to say. And you keep on talking until they ring the bell. So I think the other things have already been mentioned. So don't let me go over it again. Thank you.
Okay, thank you so much, Chief. Thank you, Chief Chief John, the Chief Oyewuze. All right, so we'll go over to the next presenter, number 2, and that's to be taken by sorry, I don't know, my stuff is not going over. Okay, that's Dr. Grace. Dr. Grace.
Good evening, everybody. Good
Yeah,
evening.
good
Can you hear
evening.
me? Am I audible?
Yes, you can.
Please. Good evening, everybody. Okay,
Good
so I'll be
evening.
taking number 2 of October, April 2022 Osce question. The question goes thus: a patient presents with cardiac tamponade. What are the clinical features of cardiac tamponade? What are the echo findings of cardiac tamponade? How would you manage the patient? So, as a form of introduction, cardiac tamponade is a life-threatening medical emergency that is caused by accumulation of fluid in the pericardial space, resulting in reduced ventricular filling, and then this will cause subsequent hemodynamic compromise. Now, it could lead to complications such as pulmonary edema, shock, or death. And basically, the presentation depends on the rate of accumulation. It could be an acute presentation, a subacute, or a subacute presentation. So for the acute, it's usually following rapid accumulation of fluid in the pericardial cavity, while the chronic, and for the acute, normally the fluid volume is usually small. It could be as low as between 100 to 200 mils. While for the chronic, this usually occurs following slow accumulation of fluid that takes a longer period. And even with light, and what happens in this scenario is that because the fluid accumulates at a slower rate, there is a stretching of the pericardium to accommodate more fluid. So up to before you have you can have large pericardial effusion before eventually they present with features of tamponade. So you can have up to more than 1,000 mils or more before you have features of tamponade in them. Now for the anatomy, a brief anatomy of the pericardial cavity. The pericardium actually is the outermost covering of the heart, and then it has two major covering. Two major layers. We have the outer fibrous pericardium, which is the thicker ones, and then we have the inner serous pericardium. And now the serous pericardium is further divided into the viscera and the parietal pericardium. The viscera is the part that covers the pericardium and the heart directly. Now, in between the visceral pericardium and the parietal, that's where we have the pericardial cavity. And the normal volume of pericardial fluid that helps to lubricate and keep the heart protected is about normal. In normal individual, is about 20 to 50 mils. That's the volume that is usually found. Now, the acute causes of pericardial tamponade could be one. Acute causes could be secondary to cardiac trauma. It could be as a result, it could be iatrogenic following surgical interventions, such as post-cardiac surgery, It could be post-immunization. It could also be as a result of post-other causes could be anticoagulation. It could also be as a result of uremia in CKD patients. Then other causes could be as a result of
Dr. Grace, I can't hear you again.
Hello, can you hear me? I'm sorry. I think I was a hitch with my
No
network.
problem. No problem. Thank you. You can continue, please.
Okay. So other acute causes could be secondary to post complications from myocardial infarction, like once there's a free wall rupture that could cause tamponade. For the subacute causes or chronic causes, it could be following secondary to malignancy, such as breast cancer, lung cancer, mesothelioma. It could also follow pericarditis, which could be viral, such as in HIV infection, follow bacterial, such as to fungal infection. The post-radiation, it could also be secondary to connective tissue diseases like SLE, systemic lupus erythematosus. It could be following in secondary to rheumatoid arthritis. It could be secondary to dermatomyositis. It could also be as a result of hypothyroidism, and it could also be idiopathic. Okay, so those are the major causes. Now, the A part says, what are the clinical features? So patients with cardiac tamponade, they can present with symptoms of the underlying causative disease condition, or they can present with, like, maybe following myocardial infarction, they can present with a chest pain, following trauma, they can present.
Sorry, Dr. Grace, I think you're having a hitch with your network.
I think it's my own network was better than her own.
Or aortic dissection. Now, the type of aortic dissection that can cause cardiac dissection, it can be secondary, present with they can
Hello, Dr. Grace, we can't hear you anymore. She's still on the call. Yeah, I think she's partially in. So let's just wait for her a bit too. Thank you.
Until now, I don't know why it's happening at this point. Hello, am I audible?
Yeah, you're heard
Hello?
now. You're being heard.
Yes,
You're being
we
heard.
can hear you now.
You can proceed.
I'm seriously sorry. I don't know why the network is flawed. Wow. Okay, so they can present with dyspnea. They can present with palpitation. They can present with orthopnea. They can present with muffled Beck triad. They can present with distant out sound, muffled out sound, with this features of raised jugular venous pressure or distended neck veins. They can have hypotension. Also, other presentation, they can present with pulsus paradoxus, Now, they can also present with tachypnea, tachycardia, which is like a compensatory mechanism during the at the early phase of tamponade. Now, there was something I should have discussed about the three phases of pathophysiology of tamponade. At the first phase of tamponade,
We have lost her again at the critical point.
Okay, Dr. Grace, I think you can proceed.
Presentation. The intra is as the fluid accumulating. Hello, can you hear me? Hello,
Yes, continue.
No, we
Just
lost
continue.
you. Start that three phases of cardiac tamponade you were saying it.
All right. She isn't here. She's not here right now. So I think we would proceed to the next. Okay, she's partially in. Let's see how we can just manage with her to finish this presentation. Let's just see how we can manage. Because I've actually stopped recording. I just want her to be done. Dr. Grace. Yeah, you can unmute your mic. You're muted. Dr. Grace, you can unmute.
Sorry, I'm so sorry.
Okay, so you can proceed. The three
Okay,
phases.
I'm
unmuted. No, just continue. Just proceed.
Okay, so the first phase.
Stopped at the three phases, yeah.
The first phase is accumulation of pericardial fluid. And then this will cause impairment of relaxation and then filling of the ventricles, because the pressure now in the ventricles will now increase. So at this initial phase, the ventricular filling pressure are higher than the interpericardial pressure. By the second phase, there is further fluid accumulation. So the pericardial pressure now increases above that of the ventricular filling pressure. This will now result in reduced cardiac output. So at the third phase, there's further fluid accumulation leading to further reduction in cardiac output. And at this stage, it will affect, that's where you now get the classical features of cardiac tamponade, that's the pulsus, paradoxus, and all that, you know. So those are the basic, and at that phase, at phase 3, there is equilibration of the pressure in both the pericardium and the pericardial cavity and the ventricles. So those are the three major phases of tamponade. So the echo features, normally echo is the major, it's fine. Cardiac tamponade is a clinical diagnosis. However, echo will help us in confirming that diagnosis and then in taking the necessary appropriate intervention. Okay, so echo, what are the features that we see? There is early diastolic collapse of the right ventricular free wall. Then there is a late right atrial collapse, is also diastolic of the right atrium. There is late diastolic compression of the right atrium. Then there is on echo, we can appreciate what they call, it's not, I don't know if I should say this, what they call interventricular interdependence. So once the fluid is coming in, because there's no space to expand into the cardiac cavity, the interventricular septum, once there's the right ventricle, once it's getting filled up, it will move and compress and reduce, and the interventricular septum will move towards the left ventricle and reduce the cavity of the left ventricle, and vice versa. So during inspiration, there is movement towards the left ventricle to reduce, and during expiration, the reverse happens. Okay, so we can appreciate that too in very massive pericardial effusion. Then there's inferior vena cava plectorial. That's another thing that can be appreciated with minimal or no collapse with inspiration. That's that there's dilatation of the IVC without collapse. The collapse is not more than 50%. Then there's also another thing that is seen. There's a greater than 25% decrease in inspiratory flow across the mitral valve. So the mitral flow is reduced in inspiration. So the peak E wave is reduced by 25%. And that happens in inspiration. Whereas the tricuspid, there's an increase by 40% in inspiration. So the those are the basic echo findings for cardiac tamponade. So the management of cardiac tamponade, basically, there's a need for it's clinical. With once we say patients presenting with hypotension, presenting with muffled sound, distended neck veins, that is pulsus paradoxus, tachycardia, tachypnea. What comes to mind is cardiac tamponade. So they may further have features of right ventricular systemic congestion. There may be pedal edema, hepatomegaly, ascites. Then based on the underlying clinical condition. So basically, the main thing with high suspicion, we want to quickly confirm. Once we confirm, before we confirm, of course, we want to know what is the likely etiology. So there's a need to quickly take a quick history from the patient. You want to know if the patient is a known patient with CKD, or if the patient was treated recently for a viral, or had a viral infection recently, or had a fever, or had been treated for TB in the past, you went for surgery recently, or if there are history suggestive of background connective tissue diseases. We want to take history along that line. You want to ask for joint pain, you want to ask for fever, you want to ask for history of recent surgery, cardiac surgery specifically, and then, or any intervention that was done, a pacemaker insertion and the likes. Then if for malignancy, you want to ask for things like weight loss, malaise, generalized body weakness, and so based on the history, once we quickly take a quick and we examine, we need to confirm using echo. So we may need to do some other investigations. We want to quickly check supportive investigation and definitive. On ECG, what we'll see is sinus, there will be tachycardia, there could be electrical alternance. So basically what that means is there's alternating QRS, variation in the QRS, there's variation in the length of the QRS deflections. Another thing that could also be seen is low limb leads complexes. The QRS complexes in the limb leads are very low. Then that's basically for the ECG. Then for echo, I've mentioned those ones. Then other things that we can do on chest X-ray, there's the globular heart. That is what is seen. The heart is really very big and it looks globular. Then we want to do other things to just be sure, baseline. We want to check the full blood count. You want to check the platelet counts. You want to ask for history of anticoagulation use, antiplatelet use. so that we want to assess the likely if the patient is prone to having bleeding during the. So the main treatment, the truth is, for cardiac tamponade is intervention. Is either we are doing a pericardiocentesis, depending on if that's the first presentation, or we want to put in a pericardial window if there's history of recurrent cardiac tamponade, or in the cases of surgical, like or you want to do a surgical intervention. So it's not all cardiac tamponade that you need pericardiocentesis. So you want to drain. So depending if the patient presents as features suggestive of hemodynamic compromise, there is hypotension, patient is really bad, you may not, with the pericardiocentesis will be done without ultrasound guidance or fluoroscopy. So there is no need for imaging at that point. It's really an emergency, and you really need to stick in that needle to withdraw the fluid. Now, when doing a pericardiocentesis, but if not, if the patient is still relatively stable, you can take the patient to a proper lab, and then we proceed and do a pericardiocentesis. Now, while doing it, you may need to drain at intervals. So we don't want to drain more than 1 liter at once, because it can cause worsen the patient, can cause a right ventricular collapse. So we are careful, we don't want to drain more than 1 liter, depending on how much fluid has been accumulated. So we do it at interval. So while draining, we may need to clip to stop the drainage along the way. And then you may need to put the catheter that we are using inside too, that's the pigtail catheter, till we get less than 25 mils in the pericardial cavities. That's when we can now remove the drain and then close up. So in the case, like I said, if there is recurrent history of recurrent accumulation or pericardial tamponade, you may need to put in a pericardial window, and especially in cases like people with connective tissue diseases, people with malignancy, we may need to do that. So other things to take note. Okay, so for the surgical intervention, like if a patient has cardiac tamponade following aortic dissection, you need to do a surgical intervention. So that's actually that's the only contraindication to that's not the only. So most of the surgical intervention, those is either you are doing you are draining, doing a pericardiocentesis, or you are doing a surgical intervention. So cases where you may need to do a surgical intervention include dissecting aortic dissection type A, or if there's severe chest trauma, you may need to do an intervention, or if there's history of ventricular free wall rupture following a myocardial infarction, you may need to do a surgical management. Then if there is arterogenic hemopericardium that cannot be stopped percutaneously, you may need to do a surgical intervention. I think those are the ones that you may really need to address surgically without putting in a drain. I think basically that is all.
Okay, thank you. Thank you so much, Dr. Grace. Thank you so much. We appreciate it. All right, so okay, so now in managing this patient, it's an emergency. So what are those few things you're supposed to do immediately in managing a cardiac tamponade? It's an emergency. Like, yes. What are those 5 things you would do?
Okay, so like I said, if the patient is stable, like there's no cardiovascular collapse, it's a life-threatening emergency. So if the patient is really very bad, he's tachypneic, he's hypotensive, there's tachycardia, you may just need to stick in the middle, just, clean the space and just start. While you now proceed further to put in to do a proper pericardiocentesis. Okay, so there's a need to really assess that patient and know if you may need to just save their life right there and then. rather than going for a proper pericardiocentered.
Okay, then, just to add on it, like you can do the ABC resuscitation. You
Yes.
can give oxygen, depending if the patient is
Yes,
desaturated,
you can give oxygen.
Then volume expanders, now because cardiac output is reduced, volume expanders.
Well, you are
Then there's a
careful with all
part
these
where,
things, actually.
yeah, but very careful anyway. Then there's a part where, depending on how compromised this patient is, you can actually place the patient on bed rest and then elevate the leg. The leg
Yes,
of
that can help while we are waiting for the
it helps to
procedure.
increase venous return. You
Yeah.
understand, to that patient. Then you do an immediate pericardiocentesis or pericardiotomy, whichever. Then after you can now treat the underlying cause, just to get
Yes,
the
you have to
patient
treat
out of that
the thing. You
tampiness.
have to treat the underlying cause. Yes,
Then
I skipped that.
after you're done with relieving the patient of that life-threatening aspect. All right, thank you so much. Okay, so the floor is open to questions and contributions. Thank you.
Yes, hello.
Thank you.
Hello, Florence.
Yeah, we can hear you.
Okay, so I just want to contribute to the first part of the question, the clinical features. It would help if you just go orderly, the way we do the clinical examination. So you start from the history aspect. What are the complaints they will present with? So if they're already in tamponade, of course, they will have difficult breathing at rest. But if it is a subacute or a chronic form, before they present, they would have been having symptoms of cardiac insufficiency. They're having dyspnea on exertion. They will be noticing edema, and especially those who have the chronic form, because of the large volume of fluid accumulating in the chest. Some would explain to you that they feel this heavy weight in the chest, like there is some weight in the chest that they feel when they go around. Okay, so and then after you and then you must mention also that depending on the cause of the disease, they might have other, non-specific features, maybe fever for the infectious causes, or maybe an underlying malignancy that is causing the problem, weight loss and all of those. So those other constitutional symptoms will also be present based on the etiology. And then when you go to the examination findings, you just follow the order of the cardiovascular examination, and then you'll be able to say a lot more and not miss out very importantly. So from the pulse will be small volume, very fast and sometimes steady when they're in tamponade. Moving to your blood pressure will be low. Okay, the JVP will be raised, and then going to the precordium, you have distant heart sounds. Okay, and then you mentioned the Beck's triad, where you have the low BP, raised JVP, and your distant heart sound. Okay, and also in the chest, your EWAT sign, when you auscultate the left lower part of the chest, find crepitations because of compression of the lingular lobe. You mentioned that coming down to the abdomen, there will be hepatomegaly as well because of the congestion on the right side. Okay, so when you take it orderly as you examine, it helps you, not to miss other things that you find in the examination. But it was a good summary of comprehensive presentation of the findings. Thank you.
Thank you, Dr. Conte. Thank you. We appreciate it. All right, so the floor is open to more contributions and questions from the participants. All right, so in the absence, all right, okay, you can talk.
Thank you very much, Dr. Grace. Please, if you could go over the echo finding again, please. Thank you.
Okay. Okay, so I said there'll be, first of all, there'll be we can appreciate what they call intraventricular interdependence. Okay. That's not a major thing they emphasize on. Okay. But other things, there could be early diastolic right ventricular collapse. That's the right ventricular wall collapse. It's an early diastolic collapse. Then there's a late diastolic right atrial collapse. Then there's IVC, inferior vena cava plectoral, with minimal collapse in inspiration, minimal or no collapse during inspiration. Then there's a reduction in the mitral inflow. That's the peak E wave is reduced by 25% in inspiration compared to expiration. And then also for the tricuspid, there's a reduction in the peak E wave by 40% during inspiration too. Those are the major things. Then they could also be in the setting of a large effusion. You may see the heart swinging, the swinging heart, surrounded by the large pericardial effusion. So those are the major echo findings.
I think
Thank you for
don't forget to add that
this wonderful presentation.
Sorry?
That IVC plethora is the earliest and the most specific. Is the most sensitive rather. Most sensitive. Most sensitive.
It's about 97%.
Exactly. And the tricuspid and the mitral, transmitral reduction in EA, they are also both specific too.
Thank you.
Thank you for this wonderful presentation. We have all improved in our knowledge, especially. But importantly, we must not forget that if we know these things and we don't say that there is a pericardial, just like you remember it now, pericardial effusion and then massive and swinging heart in the pericardium. I think it was one of those exams the mentioned, and I asked, where is this? Is there fluid? Is there a fluid in the pericardial space? So it's actually one of the first important things we established, that there is massive fluid in the pericardial space with the swinging, with the heart swinging inside the pericardial sac. And just as Dr. Conte was saying, when you were mentioning the clinical signs, we are more interested in the clinical features, symptoms, and signs of when symptoms of comorbidities. We may not have enough time to now go into the symptoms of cardiac tamponade. You know, these exams, they try to divide. You have the pharmacology session. This is the medical emergency station. So, and in that medical emergency session, the cardiac tamponade is there. Patient is before you with those clinical with the features of the cardiac tamponade, as already mentioned. The patient is having shortness of breath, is complaining of a chest pain that is worse on lying down and relieved in sitting up position, a sharp stabbing chest pain. And we should not forget to also mention that chest pain, that characteristic of that chest pain, are quite important in what they are also looking out for. And as we now go to management, we must also remember to say that this is a medical emergency. And a quick history, we'll take a quick history, and then to confirm the symptoms, as we have already discussed, because we've already discussed the symptoms, so you don't need to start, we may not need to start mentioning it again, as confirm the symptoms as we've already discussed, the clinical findings as we've already discussed, and then we can now go to the investigations and the echo. I think because if we have that time, because what they want, they will also want to check and be sure that we'll be able to describe that pericardiocentesis. That's what they will do, because definitely they will now ask, how would you now do the pericardiocentesis?
Hello, Dr. John.
Hello?
Okay, you're asking for what? The procedure of pericardiocentesis.
No, I was, yes, if we can discuss, because that's where the question, the cocoa of that question.
Okay, now you can help us now. Let's start with you.
Well, let me see what I want to remember. Is one of the emergency procedures, and she just mentioned is a sterile procedure, and will require an echo guidance to perform the pericardiocentesis. And there are actually two access routes. I think the Xiphistana route, I remember that very well. There is another access route at the lateral side, so I may not remember that one. And the pictal catheter and the epical route, yes. The Xiphistana route and then the epical route. But the commonly used and then the easier to perform is the Xiphistana route. And you are supposed to, is an aseptic process, as we said, and you gown and then do all the necessary aseptics, wear the sterile glove, and clean the Xiphistana area with Savlon and then the povidone iodine, and under echo guidance, advance the pictal catheter, and be able, as you advancing it, once you get a give, you will now notice you are already in the pericardial space, and you will now be able to take out the cannula and put the other catheter and use the cork. I think that's the one that has a control cork or whatever to control the fluid that comes out. That's any other additions can come in.
Okay, so I think what's me I can just add on here. First and foremost, you place the patient in 30 to 45 degrees, and then you make sure the patient has like an IV access, and then the patient should be on supplemental oxygen, and then also be on cardiac monitor. Then there should be this continuous, patient should have this pulse oximetry attached, so we can also know the oxygenation and all, to know what the oxygenation is like. And then patient should be placed on, should have an NG tube. That will help to decompress the stomach. Then also we would have to identify the landmark, that's the anatomical landmark. Identify the xiphoid process, that's the fifth and the sixth rib. And then most commonly the sites are the left sternocostal margin or the sub-xiphoid approach. Then, as you said, it's an antiseptic procedure where we have to infiltrate that site where the incision will be made. Then basically, I think we puncture the skin with a blade at that the site that's between the xiphoid process and the left sternocostal margin. And then we'll now connect 20 to 60 mils of the syringe to the spinal needle, and then aspirate like 5 mils of normal saline into the syringe. Then while we're advancing the needle, there will now be like an occasional injection of up to like 1 mil of normal saline that will help also ensure that the needle lumen, it remains patent. So I think, and then basically this it's a spinal needle they use, right? So the spinal needle is now placed through the skin. You understand, the skin incision, and then what happens is that we'll direct it towards the left shoulder, and then we'll make sure that the needle is at 45 degrees angle to the abdominal wall, and then also 45 degrees off the midline sagittal plane. So then if this permits, then the needle insertion should now be performed under a direct ultrasonography guidance. So there will now be like a slowly advancement of this spinal needle up to like 5 cm below the skin or so. Then basically what happens is that we'll now apply a negative pressure on the syringe until there's a return of fluid. You understand? Return of fluid, say return of fluid, getting backwards. I think that's when you now feel like you're in the space or something. But what happens is that you have a give, you feel a give. And when you feel that give, that's when you know that you've actually penetrated into the pericardial space, and then you feel a backflow of blood, backflow of the fluid into the syringe. And that's what I can say. I don't know if we have any additional thing as regards that. But although there are some parts where you have to take some extra maneuvers, I don't know. Maybe someone can help to assist with that.
And then we must also discuss about the informed consent, either written, signed consent too. And you also want to discuss the procedure with the patient too. Possible complications that could arise too, which can be cardiac puncture, laceration, pneumothorax, hemopericardial, infection, sepsis, the vasovagal reactions can also occur. And then just to improve the yield, or just to improve the, can be echo guided, ultrasound guided, or even fluoroscopic guided, just to avoid those complications.
All right, thank you. I don't know if there are any add-ons. Okay, so yeah, okay, somebody said pericardiocentesis can be either diagnostic or therapeutic. For cardiac tamponade, it is therapeutic. It's a therapeutic pericardiocentesis. It can be diagnostic too, because I think we can send the sample. We can send the sample for we can do, I think, adenosine deaminase to rule out TB, because we know that this other one, gene expert, is not so specific. I think adenosine deaminase is better. Then we can do microscopic ultra and sensitivity. We can also do cytology too, to check, to help to
cytology.
rule out. Yeah. Then we can do fungal study on it. So it's both diagnostic and then therapeutic. You understand? It's relieving the patient of the symptom, and we can also make diagnosis to know what exactly is the cause. Thank you so much, Dr. Ila Lincoln, for your contribution. So I don't know if we have any other things that we can hand over to our chiefs. All right, so in the absence...
Sorry, there was something I missed out that is important for the JVP. Okay, so there's absent wide descent. That's because of the impaired feeling, you know. So there's absent wide descent, there's prominent in cardiac tamponade. Thank you.
Okay, thank you. Thank you so much. All right, so we'll hand over the class to Chief Orimolade and then Chief Adi Andrew. Okay, Chief Orimolade.
Yes, thank you. Thank you so much, Dr. Akeredolu. Thank you to all those who have contributed for at least refreshing our brain on pericardiocentesis. That's fine. Cardiac tamponade is an aspect of the exam that we cannot miss. It will surely come out. The echo features of cardiac tamponade came out in our own exam, and I know it will still come out again in MCQ. So there is a way all those plethora, less than 50%, the collapse, right ventricular collapse, right atrial collapse, which one is asystole, which one is diastole. You must not see it in exam and be confused. So please, let's go over it this night, and in fact, cram it. It will come out, and you have to choose just one answer. Do you understand? Because they are going to write so many things there, and they will expect you to choose the most perfect. So at times, instead of writing systole, they write diastole. Instead of writing diastole, they write systole. It keeps so that you can be confused. So please, you have to know the echo features, echo parameters of cardiac tamponade. It will come out in your institute. I can assure you. That one is one. Then two, when we're talking about management, yes, pericardiocentesis, that's the mainstay, that's the goal of management, and which can be done using various means, either as an emergency. The commonest site when you are doing emergency is the civil standard, because they will ask you in exam. The moment you are saying it, they will tell you which one have you done. Do you understand? Which one have you done? how you understand which one is actually visible. So you can do urgent one, like you said, which is this xiphoid area, and we can do using ultrasound or fluoroscopy or whatever guided. The one we do mostly in most of our centers is echo guided, so which we must mention. And with the CTSC too.
Okay, Chief. I think she's having a network. She's not on the call anymore. This is just exercise patient, eh? I think she's having a network problem. Dr. Ojo, please, can you just communicate with her? Because she may be thinking she's still online, but she's not online right now. Can you just communicate with, okay, she's coming back.
You might not have to remove it immediately. So you must understand pericardiocentesis in management. You must understand pericardiotomy. In case they ask in an exam,
We
that what's
lost
the
you long
difference? Please, we
ago.
should note. Hey, Jesus Christ. So please, where was the last time you lost me? Oh, I've said so many things. Sorry. I'm so
You
sorry.
talked
It's
about
network.
the epistemium access being the fastest during
For the
pericarditis.
emergency. Yes, that's for the emergency for pericardial stentosis. That's what I'm saying. And then also the ultrasound guided. They might ask that which one is done in your center with the
Network, oh, Jehovah. Okay. Her network, she's having a challenge with her network.
Hello?
Yeah, hello, yeah. Dr.
Yeah,
Sambo.
where did
that
they put
my
their own needle?
oh god.
How did you cover your probe? All those things. So you should please know how all those things are done. You put your probe, try to do at the apex while they will enter through this intestinal. And what are you targeting? You are bringing your distance to the where the right ventricle is and the right atrium, because that's where they normally want to point out. They will tell you what will you see. You see the structure. Now when the needle goes, you tell them that you see go, because they will ask, how will you know you are in the heart? How will you know all those things? They will just start frustrating one's effort, but just have an idea. Your probe will be at the apex, and you might not be able to stand on the right side of the patient. You might have to go to the side because they will be on the right side. So all those things you just tell them so that they will know that you've been doing before in case this question comes out. Then I was saying that we should know the difference between pericardiocentesis and pericardectomy. Dectomy or pericardiotomy rather. Pericardiotomy is that the tube will be there, which might drain for 2, 3, 4 days, which is what we do most of the time. You allow it to drain until it has stopped draining, or until you have found a cause, so that you will know if you have to remove your tube or you have to do something else. And they do that one usually in the theater, where they're able to do some scope, and they take some biopsy through their scope. You understand? So we should know that pericardial sentences, you might not leave the tube there. Tomy, you will leave the tube there to drain. At times, you remove after 1 hour. After 1 week, or when the tube stops draining, I should know when it's not active again, when the amount of fluid is less than 50 mils. Just like you told us that the amount of fluid normally that surrounds the heart is about 30 to 50. So when it's about 50 mils, draining in 24 hours.
Thank you, Chief. Okay, but Chief, there was a point we missed out on you. Oh, she's off again. Hi. Dr. Sambo, you wanted to say something?
Yeah, I just wanted to present because I'm not
No,
home. I need to I can go back home.
Okay. After you'll be the next person to present, please. Sorry for you should have told me on time. Sorry, dear.
okay. Sorry about my network. Oh. Let me just say this last thing so that I can, if the network will still permit me. When we are talking about the management too, aside the drainage, we also treat the etiology. We should not forget that in our management, we treat the etiology. We should know that we calculate our Type score. If it's suggestive of tuberculosis, you start empirical treatment for TB. We should note that. We should also know that if it's as a result of connective tissue disease and all those things, we would have to start steroids and some other things. So we should not stop at just drainage. You should go on to say you look for the etiology and we'll treat the etiology. We should not forget treatment of etiology in what we are managing. And remember that the last time we mentioned AP study, TB is the commonest cause in our environment of pericardial effusion, which can lead to tamponade. And if it's malignancy too, the appropriate. Just make sure you get to all those things in management of the etiology, and we should not stop at only drainage. That's what I wanted to add for the management. Thank you.
Thank you, Chief. All right, thank you. So in the absence of further contributions, we'll go over to Dr. Sambo. Dr. Sambo, okay, your number is 3. Oh, you're even the next person. All right. Okay, so Dr. Sambo, you can please have the floor. Thank you.
All right, thank you. Good evening. So I'll be answering question 3, and the question: World Heart Day was celebrated in September 2022. What do you understand by use heart for a heart? So this question, the theme for that year was actually use heart for every heart. So that's like a recall error. And then the next question is, what are the 3 themes for World Heart Celebration that year? Elaborate them. So I actually made just a small presentation for this. Dr. Conte, can you unshare so that I can share my slides?
Sorry, Dr. Sambo, please, what's the theme for our World Heart Day, I beg, this year?
I thought we agree you use the World Heart theme for this year.
Sir Datu.
Can you see my slide?
Yes, we can see. Sir Datu.
Yes.
Sorry. Okay, sorry.
Don't worry.
Okay. Have a presentation for that one too, right?
Have a presentation for World Heart Day.
No, like this year's one.
Don't worry, Dr.
All right. Okay, I trust you. Thank you. I trust you. Thank you.
This is observed annually on September 29th. Awareness about cardiovascular disease.
No, they call you now. You don't come out. You don't say now.
Dr. Brown. Can I still be heard?
Yes, you can be heard.
Okay, so this was established by the World Heart Federation in 2000, and the day emphasizes the importance of adopting healthy lifestyle to reduce the risk of cardiovascular diseases such as heart attacks, strokes, and the others. So in 2011, World Heart Day became an annual event that bringing people together to increase awareness, engage communities, and advocate for universal access to cardiovascular disease prevention, detection, and treatment. So the themes for World Heart Day. So for last year, that's 2023, the theme was use heart, no heart. So this focused on increasing awareness of heart disease by encouraging individuals to understand their heart health and take proactive steps for prevention and care. Then in 2022, which was the question that was asked, the theme was use heart for every heart. And this theme highlighted the importance of using knowledge, compassion, and influence to care for everyone's heart, especially those in vulnerable communities with limited access to healthcare. So that year, the theme was followed by 3 pillars, which were use heart for humanity, use heart for nature, and use heart for you. So these were the pillars. So for use heart for humanity, they were advocating for equity in assessing cardiovascular health. Then for use heart for nature, that's for the planet's health and yours. So air pollution, they were trying to curb air pollution and other environmental factors that affect cardiovascular health. And use heart for you is to realize your full potential and avoid psychological stress that can affect your heart, and adopt more of a less stressful activities and lifestyle to improve your heart. So use heart for humanity, use heart for nature, and use heart for you. So that this were the questions that were asked that year. So for 2021, the theme was use heart to connect. For 2020, use heart to beat cardiovascular disease. And for 2019 to 2018, the theme were my heart, your heart. So for this year, the theme is use heart for action. So this theme would hold from 2024 to 2026. We'll campaign under the theme for use heart for action, supporting individuals to care for their heart and empowering them to urge leaders to take cardiovascular health seriously by providing a global platform for action. It highlights a shift from awareness to empowering with a clear purpose and goal. And there are 2 ways that would be used to achieve this. So one of them would be efforts to influence policies, and then advocate for behavioral change and physical activity. So it reflects the requirement for sustained efforts and collaboration. So the campaign for this year would be our global platform for action aims to give heart a voice. So this 2024 World Heart Day campaign is dedicated to motivating every country to develop and support national cardiovascular health action plans. High-level decision makers are needed to make a difference, but everyone has a role to play: the professional community, the patient, and the general public. So there's a petition on their website, okay, and they are advocating to collect over 1 million signatures for cardiovascular health and save lives. This petition is for all who care about the better health and having access to diagnosis, care, and prevention of diseases. Okay, and they are advocating for us to sign now so that we can urge leaders to take action on cardiovascular disease. So this is just a summary of what I said, with the theme use heart for action, the campaign, and then the petition. So there is also a challenge for the World Heart Day. Create your own heart-shaped route to walk, bike, or run. Share your routes on the World Heart Federation site to add it to the challenge wall, and then you share on social media using the hashtag World Heart Day to inspire others to create their own or try your route. So this is just an example of a heart-shaped route that people are going to walk or bike through, and then they'll post it on their website and on social media. So this poster is also one of the posters for the World Heart Day. Demand action to save lives. Heart, yes. Okay, and then it's also advocating for you to sign the petition. So I'll also talk briefly about World Hypertension Day. So this is observed annually on May 17th to raise awareness about hypertension and its a significant role in increasing the risk of cardiovascular disease. Okay. The event was established by the World Hypertension League in 2005 to promote public education and encourage prevention, detection, and control of hypertension. And since then, World Hypertension Day has been ever expanding yearly event. So the theme from 2022 to 2024 has been measure your blood pressure accurately, control it, and live longer. As at 2021, they didn't include the term accurately. It was measure your blood pressure, control it, and live longer. So the objectives of the World Hypertension Day is to increase awareness of the risks associated with high blood pressure, including its silent killer nature, encourage regular blood pressure monitoring, and promote early detection, especially in communities with limited access to healthcare. Promote healthy lifestyle changes to lower the risk of hypertension, including adopting a balanced diet, encouraging regular physical activity, reducing salt intake, quit smoking, and manage stress. So the objectives are to highlight the importance of treatment and medication adherence for those already diagnosed with hypertension. And on World Hypertension Day 2024, that's the one that was done this year, the World Hypertension League announced the contributions of the Children's Art Program for promoting hypertension awareness in youth. Then there's also May Measure Month. It's a global blood pressure screening awareness campaign that was launched in 2017 by the International Society of Hypertension. And since 2017, volunteers in more than 100 countries have screened people in cities, towns, and villages as part of the largest free public blood pressure screening program in the world. So this May measurement, it took place between 1st of May to 31st of July this year, and it built on the World Hypertension League established World Hypertension Day with volunteer health professionals at screening sites in more than 90 countries. So the objectives were to highlight the importance of measuring your blood pressure and to raise awareness of the dangers of elevated blood pressure and hypertension, increase the numbers of participants aged 18 and above who are regularly getting their blood pressure checked, and also provide diet and lifestyle advice to those with hypertension. And on a broader level, the MMM uses the data on inadequately treated hypertension to motivate governments to improve BP screening facilities and reduce the burden of this disease. So this were the questionnaire that were used to collect data for the May measurement 2024. Okay, so yeah, thank you for listening. I'll send the slide on the group. Unfortunately, I have to sign so that I can go back home. So if there are any questions, maybe you can type them and I'll answer when I'm able to. Thank you.
Thank you so much. Thank you, Dr. Sambu, for taking your presentation. We appreciate it. Okay, so as she said, we would have to send to the platform, like the chat room, or maybe to our WhatsApp page, if you have any question as regards that. All right, thank you. So I don't know if we have any add-ons. Do we have add-ons?
It's for us to understand the key three aspects, which is the team, use her for action, and then the campaign, which is to raise awareness about cardiovascular diseases and influence government policies for the right action, and then the petition that is being signed towards it. I think this is the summary of the the three pillars of the World Heart Day of 2024. And then it's running between 2024 to 2026, while that of World Hypertension is running between 2022 and ending this 2024.
All right. Okay, so thank you. So I don't know if we have any participant has any contribution. All right. Okay, so we'll hand over to our Chief Orimolade. Thank you.
Yes, thank you, Dr. Florence. God bless Dr. Sambo. That's actually what we need for this exam. Thank God that you talked on the World Hypertension Day too. That was quite commendable. Thank you so much for the effort. So I think just like Dr. John really said, we should note those the things and focus, like he has said. Then you should not forget the dates for both World Heart Day and the World Hypertension Day. So they can hurt us, we should not forget. So that's also quite important. Those dates are important. And you know, now we have our vice president to the call. So you should know the name of the president of the Wacp Federation, name of the vice president, which is our own person. So they can just bring, suspecting that they might bring something. Then when was she elected? When was she formally announced? All those things, just for political reasons, let's know. So when she was elected and when she was announced as the vice president, we should know. Then if anybody also has any information as regards what current thing has happened in, okay, they said she's the first female, all those things, so we should, first female vice president or something. So we should also note that. I think that will be all. Thank you so much, Dr. Sambo.
Okay, thank you. Thank you so much. Since we don't have any further contributions and questions, move on to the next presenter for today. And that is Dr. Neka to take number 4. Is Dr. Neka here? Okay, she's here.
Yes, I'm here.
Okay.
Okay, good evening, everyone.
Good evening.
Number 4 says, discuss the commonest primary cardiac tumor. A, is it associated with any complex? If yes, which one? And then B, what are the components of this complex? So talking about cardiac tumors, they are tumors found in the heart. They can either be primary or secondary. The secondary tumors are usually the common ones where you have metastasis from distant organs like the lungs, the breast, or the skin, like in the case of malignant melanoma. So when you have these malignancies migrating to the heart, those are your secondary cardiac tumors, and they are the commonest. For the primary cardiac tumors, they can either be benign or malignant. The benign one, specifically atrial myxoma, is the commonest primary cardiac tumor. And alongside the same benign primary cardiac tumor, there you have the papillary fibroelastoma, then you have your fibromas, your lipomas. And then for the malignant primary cardiac tumors, that's where you have your sarcomas, whether your rhabdosarcoma or rhabdomyosarcoma or your angiosarcoma and even lymphomas. So talking about the commonest primary cardiac tumor, it is the atrial myxoma. It's a benign cardiac tumor that is commonly located in the left atrium. However, it can actually be seen in any chamber of the heart, the left atrium, the right atrium, the left ventricle, the right ventricle. And also it can be seen on the cardiac valves, although it's not the commonest one associated with valves. The papillary fibroelastoma is the one most commonly associated with the valves, but atrial myxoma can also be seen on the valves. So commonly you see it in the left atrium. Is usually attached to the left atrial myxomas are usually attached to the interatrial septum, just close to where you have the fossa ovalis. They can be pedunculated with a stalk forming the attachment to the interatrial septum. Now, it's said that it's commonly affects women compared to men, and the mean age of occurrence for the atrial myxoma is usually 51 years with a range of 30 to 60 years of age. The cause is usually sporadic. It just occurs in about 90% of individuals. It is sporadic. However, in the remaining 10% of individuals, it can be familiar, which is the complex we'll talk about later. So it's sporadic, and in a few percentage of cases, it can be familiar. Now, the presentations of patients with atrial myxoma. For most cases, they are actually found as, they're usually seen as an incidental finding when maybe you're ruling out or when you have any cause to do an echo. So it can be an incidental finding without any symptom. However, when they present with symptoms, they can have some constitutional symptoms like fever, which commonly would make one want to confuse them with infective endocarditis. So they can have fever, they can have malaise, they can have weight loss, arthralgia, just any constitutional symptom you can think of. Features of lassitude, dizziness, they have those constitutional symptoms. Then the other features that they have would be dependent on the size of the myxoma. Now, the myxomas can be of any size, small from 1 to almost 15 millimeters. So they can be of any size. When they are small, they are quite friable and they can easily embolize. So they can cause a stroke when they embolize. They can cause infarcts, like when they get to the renal vessels, they can mimic like the cholesterol embolization syndrome. So they can cause renal infarcts when they embolize and occlude any vessels. Similarly, when they occlude vessels, peripheral vessels like those of the toes or the fingers, they can cause all those purple toe syndrome when they embolize. So that's what's usually responsible for those features. Then when they are large, sometimes they can be large enough to occlude the valves. So in the setting of the left atrial myxoma, they can be large enough to either obstruct the mitral valve or damage the valve in a way that they press on the valve and cause regurgitation. So they can also present with features of like mitral stenosis. So you can have features of mitral stenosis, either from pulmonary congestion or features that would arise from left atrial enlargement, like arrhythmias, and so they'll present in palpitations, syncopal attacks, dizziness, and all of that. Then apart from these presentations now, they can also cause, I think they can also cause some or compressive symptoms. I'm not 100% certain, but depending on how large it is in the left atrium, they may be able to cause hotness. Please, I'll confirm that, but they can cause some other obstructive symptoms. Now, when you go ahead to examine these patients, they can have features of mitral stenosis, like I said, and you can even take them as one of the non-rheumatic causes of mitral valve disease, because they can present like a form of stenosis or a form of obstruction in the mitral valve. So you see, when you examine the apex of the heart, or when you listen to the heart, you might be able to appreciate a mid-diastolic murmur like that of the mitral stenosis. But one thing you use to differentiate is that it would not have that usual opening snap. Instead, they will have a tumor plop. Now, the tumor plop you hear in the setting of atrial myxoma is an early diastolic sound. Is usually low pitched. It's heard early diastole. just following the second heart sound, and it's usually heard at the apex. So if you hear a low pitch sound, a plop at the apex in early diastole, you suspect a tumor plop, unlike the opening snap, which is high pitch, and you hear it between the apex and the left lower sternal border. And then I think that's basically for the examination findings. Then their diagnosis, like I said, is usually incidental. When you're doing an echo and you find this mass in the chamber that it's been affected, most likely the left atrium. They are usually heterogeneous, so they can be irregularly shaped because they're usually gel-like. That's why they are easily friable. Then other investigative modalities like your transesophageal echo, MRI, or cardiac CT can also pick the tumors, but usually your transthoracic echo is usually enough for diagnosis. And for the management is usually surgical, regardless of the size of the tumor. So even if it's a small size 2 millimeter tumor, it's better to take it out because of the risk of embolization, which is their major complication. So that's that for the atrial myxoma. Now they asked, is it associated with any complex? If yes, which one? So yes, the atrial myxoma is associated with Carney complex. Carney complex, that's the familiar one I was talking about. It's just a familial variant of atrial myxoma, which is an inherited form of atrial myxoma. Is usually associated with genetic mutation in PRK, protein kinase A gene, on chromosome 17. That's the mutation. So when you have a genetic mutation of the PRKA gene, it can present with atrial myxoma and some other parameters. So the components of this Carney complex, you have the cardiac myxomas. Then you can have myxomas of other tissues, the skin, the breast, testicles, pituitary gland, myxomas or fibroadenomas of other tissues. That's another component. Then they have these pigmentations on the skin, pigmented lentiges. They have blue navy skin manifestations. And then they have endocrinopathies as well, where they present with features of Cushing's syndrome. So those are the components of the Carney complex. So the Carney complex, the myxomas, cardiac, or of other tissues like the pituitary, testicular, breast. Then you have skin, which is either lentiges, just hyperpigmentation or brown dots on the skin, or blue navy. Then you have endocrinopathies. So those are the major components of the Carney complex. Then one thing about the familiar forms, which is this Carney complex, is that they usually present younger than the usual atrial myxoma. Like I said, atrial myxoma presents usually between the ages of 30 and 60 with a mean age of 51. But for the Carney complex, they present much earlier. So you see them in individuals less than 30 years of age. They have age, I think 25 years old, I think, as the mean age for the Carney complex, which is the familial type. And then it is this Carney complex type that you usually find extra atrial sites. So they are the ones that usually have ventricular myxomas. So when you see myxoma in the ventricles, you suspect that it's likely the familial type. Then also they tend to have multiple myxoma, so you can have them in different chambers. Okay, before I forget, now remember I said the left atrial myxoma is attached to the interatrial septum. Usually the ventricular ones, they are not attached to the interventricular septum. Instead, they are attached to the free wall, the left ventricular free wall. So that's one difference between them. Also, the Carney complex has some subunits or subtypes. It's just basically names. One of them is name, N-A-M-E. What it just means is N, nevi, A, atrial myxoma, M, myxoid neurofibroma, and then E, ephelids. Hey, I said I'll check this ephelids. I've forgotten. I don't know what that thing means. Ephelids. But these are the subtypes. Then there's another subtype called LAMB, L-A-M-B, which is just lentiges, atrial myxoma, blue navy. So if you have familiar atrial myxoma, that is a Carney complex, they can present in any of these forms, either as the LAMB or as the name. So those are just the subtypes of it. Investigation and management is same as the sporadic type. That's all I have. Thank you.
Okay, thank you. Sorry, I didn't get the name. You said nevi, atrial myxoma.
Nevi, myxoid neurofibroma. That's the M. Then the E is ephelids. I don't know what that means. E-P-H-E-L-I-D-S. I'll type it on the group.
Okay. Okay, then for the other one, it said lentigens, atrial myxoma, and what? Blue nevi.
Blue nevi, yes.
Okay, thank you.
Subtype, thank you.
Okay, thank you so much. Thank you so much for taking your part. Well appreciated. All right, so the floor is open to questions and contributions from participants.
Thank you so much, Nika, for this. You were saying which one that was not. I didn't clearly get you when you said the one that is not attached to the septum. I think I lost you there.
Okay, commonly the atrial myxoma, when you find them in the atrium, they are usually attached to the interatrial septum.
Yes.
But the ventricular ones, when you find them in the ventricle, they are attached to the free wall of the ventricle, not the interventricular septum. Did you get me?
Ventricular ones.
Hello?
Hello?
Yeah?
Yes, I got you. If they're in the atrium, they are attached to the interatrial wall.
Commonly, yes.
Interatrial septum. But if it's in the ventricle, they are attached to the free wall, not the septum.
Yes, commonly. Yes.
Any further questions? Okay, so if no, we'll move over to
Hello?
Okay,
Hello?
Yeah, you can have the floor.
Then we need to know how to differentiate, because it can come out in MCQ, between the tromos and the myxomas. Just like you said, the myxomas are heterogeneous. As in when you put, of course, one is homogeneous. The thrombus, they have the same homogeneous, as in they have the same appearance. But of course, the thrombus they have is heterogeneous. And then, of course, the location too. Location, just like you said, and then the attachment, Then the pedon one is like the myxomas, they're more likely to be pedunculated. They have the attack to the stalk, the myxomas. Of course, the thrombus, they are usually free floating. It can be anywhere. Thank you.
Thank you.
But thrombus is heterogeneous or the myxoma?
Myxoma is heterogeneous, but
All right.
thrombus is homogeneous.
Okay, thank you.
Yeah, yes. Again, I think can't remember if you mentioned it.
Hello?
The commonest malignant primary cardiac tumor. I think you mentioned the commonest cardiac tumor as atrial myxoma, or the commonest malignant cardiac tumor. I think that's angiosarcoma, or in children, rhabdomyosarcoma.
Yes.
Okay, I think my network wasn't good there.
Hello?
Yeah, we can hear you.
Hello?
You can ask your
Okay, thank
question.
you. Okay, just a brief addition. Thank you for the presentation. Okay, just wanted to add some few things. Okay, like she rightly stated, atrial myxoma is commonly found as the most common site is the left atrium, then followed by the right atrium, then the right ventricle and the left ventricle. The left ventricle is the least site in which it can be found. And then aside that, when it comes to the management actually involves both medical, surgical, and then monitoring. Um, the management will require is a multidisciplinary approach.
Dr. Lekadi, we can't hear you again. Dr. Lekadi. Dr. Lalekan, we can't hear you again. All right, so while we wait for him, we will now, I don't know if any other participant has a question or contribution. Okay, so move over to our Chief Orimolade. I don't know, something about it. Okay, thank you.
Okay, thank you so much, Dr. Nika, for that detailed presentation. Cardiac myxoma can still come out in our exam. So yes, we talked about the location, but in case we see in the MCQ, the location of the origin of the intraatrial septum is around the limbus fossa ovalis. Just for MCQ and this they are biology sake. So it's the limbus fossa ovalis in case we see it in MCQ. And just like you have said, it's likely to be pedunculated in majority or in most of the time. Or we could have the one that will look like papillary, which will occur in very minute, and those are the ones she described as they are small, and they are the ones that can easily embolize. So we should note that. So the ones that are pedunculated are polypoid myxomas. Polypoid myxomas are the pedunculated ones, while those ones are more compacted and they have less tendency to fragment. But the ones that are like villous or papillary myxomas, they are the ones that can embolize. You understand? They are gelatinous, they are less compact, they are fragile, and they can embolize, leading to strokes and the likes. So that's about that. Then for clinical features too, just like she described that it could be um, missed for infective endocarditis. The reason is that they might be infected. That's part of the clinical presentation that you can have. They might be infected
And when they are infected, they present with fever. They can present with fever, cachexia. So you should have in mind in case they are thinking clinical scenario, they are asking more questions. So you should know that they can be infected, they can present with cachexia, they can present with fever too. So that's also part of the presentation. They can present with metastasis, or let me say infected metastasis or embolization, as the case may be, to different locations. Can be to the kidneys, it can be to the brain, you understand, septic emboli everywhere. So we should also take note of that. Then in the examination too, everything she mentioned was fine, but we should not focus only on the ones that are affecting the left, because most of the features that you talked about were clinical presentation affecting the left. So you should know that if it's affecting the right, you can have elevated JVP. You understand? You can have elevated JVP too, and other features of right-sided obstruction can be present. You can have features of pulmonary hypertension or pulmonary edema, as the case may be. So we shouldn't forget that. I mean, and they can be clubbing too. They can be clubbing, they can be cyanosis, they can be elevated and raised JVP. Neck veins might be engulfed, so we should not forget all that. Then all the tumor prop and the lights that she described, yes, those are perfect. But I want you to also note that in differentiating it, when they talk about is a type of the auscultative findings, let me say, that we find in cardiac enzoma characteristically will change with position of the patient. So we should take note of that in case we are asked. It will change with position of the patient. So what you hear now might be different from what you hear later, depending on the position of the patient. So we should take note of that. We've described the echo features, which I think we described them perfectly. I think that is about all. Then genetics, we should not forget genetic testing, angiography, then hematological tests too can be done. ESR be elevated in this patient. CRP too might be elevated. Patient might have anemia because of the constitutional symptoms that the patient will have. Sorry about the background noise at the background. So we have talked about the Carney's complex and the diagnostic criteria that she mentioned. So we should please go over that for MCQ purposes. I guess she mentioned acromegaly too. I hope she mentioned acromegaly, reduced test, all those.
Yes, I forgot that.
Okay, you
Acromegaly,
forgot that.
gigantism.
Yes, I've
Yes,
mentioned it too because
even
of the sake of
gigantism.
MCQ.
Yes.
Yes, for the sake, you might see that in MCQ. So you can just screenshot it. I know it's a lot. Just if you have just seen it once, when you see it, MCQ, you won't think they are asking you something that you've not seen before. But because it will be simple to just pick up and go past it. Do you understand? So thank you so much for the discussion.
Thank you very much.
Okay. So move over to the next presenter. And Dr. Sani.
Hello, sorry, Dr. Florence.
Yeah.
Sorry, I am back on. I don't know if there were any questions or contributions, but I've posted the presentation on WhatsApp.
Okay. No one had. I think it was clearly understood. It's for us to go back and then internalize your slides.
Okay then.
Yeah,
Thanks.
we didn't have any questions. Thank you. Okay, Dr. Sani.
Hello, good evening.
Okay.
Hello.
So you have to take number 6.
Okay, number 6. Okay. Okay, number 6. How does oxygen get to the body And B, what conditions affect oxygen availability in the body? And C, how do you measure oxygen levels in the body? So mention 5. And then the third is the last question is what is dead space? So this question is more like a general medicine question. So but I'll make an attempt. So to the first question, how does oxygen get to the body? So we know that in respiration. Hello, am I being heard?
Yes, you're being heard.
Okay, because I can see the network is blocking. Okay, so in the respiration, we know that there are two phases, the inspiratory and the expiratory phase. So the inspiratory phase is responsible for transmission of oxygen from the atmospheric air through the lungs into the tissues, while the respiratory phase is responsible for removal of carbon dioxide. So for the inspiration, there are some interaction between some structures in the body. One is the muscle of respiration. So this muscle of respirations for inspiration, we have the diaphragm and also the intercostal muscles. And also there are other accessory muscles of respiration. This includes the sternocleidomastoid, the scalene muscles. So during inspiration, there is contraction of the diaphragm and also the intercostal muscles. So this will lead to increase in superior-inferior diameter, lateral as well as anterior-posterior diameter. So this will increase the intrathoracic volume and also reduce the intrathoracic pressure. And it's been said that the volume increased by about 500 mils, and also averagely there's a reduced in intrathoracic pressure by about 1 millimeters of mercury. So this will allow the lungs to expand, and also so during inspiration, so the oxygen being inspired will pass through the respiratory canal, and that includes the nasal cavity, the 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 larynx, trachea, the bronchi, and ultimately to the alveoli. So it's been said that each lung has over 7 million alveoli. So at the alveoli, there will be a gas exchange, through the alveolo-capillary membrane. So what happens is that oxygen in the so now oxygen that there is being inhaled through the alveoli will now combine with hemoglobin in the capillary, so to form oxyhemoglobin. So this oxyhemoglobin will be transported into the tissue. So now the rate of oxygen delivery to the tissues will now depend on the ability for the patient to respire, the patency of the respiratory tract, the integrity of the lung parenchyma, and also the oxygen carrying capacity. So so this is so at the tissue level now, then also the carbon dioxide, you know that so this oxyhemoglobin will be transferred. So the oxygen will now bind to the hemoglobin, which will be transported into the tissue. So there are some factors that will affect this the dissociation curve now, the dissociation of the oxygen. Certain factors will affect this oxygen dissociation. So there are those that will increase the affinity and those that will reduce the affinity. affinity. So now, like pH. So if there is increased pH, that's alkalosis will increase affinity and will shift the oxygen dissociation curve to the left. While in acidosis, there will be decreased affinity. So other conditions that will affect the oxygen dissociation curve: temperature, high temperature decrease affinity, low temperature increases affinity. And then diglyphosphoglycerate also can produce produced by anaerobic process in the red blood cell. It's been found that high DPGs decrease affinity of the oxygen. So now, so this is so on the other hand, carbon dioxide is also being transported by the hemoglobin. So binding of carbon dioxide from carboxyhemoglobin, which will be transported into the alveolar capillary membrane, where it will dissociate into carbon dioxide hemoglobin. So this carbon dioxide will now be expelled through the lungs. So in summary, this is how oxygen is to the body. So to the second question, what conditions affect oxygen availability in the body? So if you look at any condition that will affect the respiratory process and also the transport of this oxygen from the through the respiratory tract and also at the alveolar capillary membrane, all these things will affect the oxygen availability in the body. So conditions that will affect muscle of respiration, motor neuron disease, Guillain-Barré syndrome, and then obstructive pulmonary disease such as COPD, and then other pulmonary conditions like interstitial lung disease, cystic fibrosis. And then, so all these things can affect oxygen delivery. And then other metabolic conditions like acidosis. And then if there is any condition like in cardiac cases that will cause left-right shunt. So because there will be shunting of the oxygenated blood to the right, so that also will reduce oxygen availability in the body. Conditions like DSD, Esimenga and ASD, all these conditions will lead to decrease oxygen availability. And then other conditions like anemia, high altitude, and then acidosis, high temperature, all these things can affect oxygen delivery to the tissues. And then other conditions that can increase the conditions like infections, acute respiratory distress syndrome, which will affect the alveoli, causing the alveolar damage. These ones too can affect the oxygen availability to the body. So how to measure the oxygen level? So measurement of oxygen concentration. There are non-invasive and also invasive methods. So the commonest oxygen method we use in our facility here is the pulse oximetry, which is one of the non-invasive methods of measuring oxygen level. So what it does is that it measures oxygen saturation in the arterial oxygen saturation. And just like I said, it's non-invasive, so it's easy to use. However, there are certain factors that affect oxygen its reliability. One is if there is reduced tissue perfusion, or if there is skin hyperpigmentation. So this will affect the the reliability in those conditions. So then other non-invasive method includes transcutaneous oxygen monitoring. So this is a modality where oxygen is monitored through skin. This is usually done in conditions where you suspect peripheral hypoperfusion, let's say in peripheral artery disease. You can, so what it does is that they use some electrodes, and then so you compare the oxygen you measure the oxygen in you look at the normal tissue as control and then compare with the abnormal tissue. So so when you apply the electrodes, you look at the absolute compare the oxygen saturation, and also you can also take the ratio and see whether that abnormal tissue is well perfused or there's some level of hypoperfusion. And then there's other modality, near infrared spectroscopy. It's also a non-invasive. So the invasive methods include arterial blood gas analysis, which measures partial pressure of oxygen, and also oxygen saturation can also provide other information, partial pressure of carbon dioxide. So then the fifth modality is the mixed venous oxygen saturation. This is a modality that measures oxygen saturation in the venous blood. So it's also an invasive method where oxygen saturation of hemoglobin in the venous blood, which reflect the body's overall oxygen saturation, is analyzed. So it's been said that mixed oxygen saturation is the percentage of hemoglobin saturated with oxygen in the pulmonary artery. So representing the oxygen remaining after tissue extraction. So we are looking at the so this is measuring the venous oxygen saturation. So to tell you the degree of oxygen saturation. Also, this can be done in other cardiac abnormalities, in heart catheterization, which will tell you when you are expecting shunt. Can use that to check assess the various oxygen saturation, can be able to tell you the location of the lesion. So, and then there are other devices that can be used, like some wrist watches have also been found to be used to measure oxygen saturation. So the last question, what is dead space? So dead space, it represents the volume of ventilated air that does not participate in gas exchange. So they are of two types. There's the anatomical dead space. So these are respiratory tracts that are devoid of alveoli. This includes the trachea and the bronchi. So and it's been found that air there does not participate in oxygen in gas exchange because it's devoid of alveoli. So this is a fixed area. So it's called anatomic dead space, and is being found to account for about 15% of the tidal volume. So that is about 150 mils of air. So account for the anatomical dead space. Then this alveolar dead space. This accounts for non-functional alveoli. And so in normal individual, the alveolar dead space is negligible. So then there is physiological dead space. Physiological dead space is a summation of anatomical dead space and alveolar dead space. So in normal individual, because the alveolar dead space is negligible, the anatomical dead space and physiologic dead space, they are almost the same. However, in some disease conditions where you have increased alveolar dead space, the physiologic dead space is increased, and these are conditions that causes ventilation, palpitation, mismatch to conditions like emphysema, pulmonary embolism, acute respiratory distress syndrome.
Dr. Sani, your voice is distant.
Okay. Can you hear me now?
Yeah, better.
Okay. So I was talking about dead space. So conditions that will cause ventilation palpitation mismatch, such as in setting of shock, or conditions that have to do primarily with the alveolar capillary membrane, like sepsis, where there's acute respiratory distress syndrome, or in emphysema. So this will increase the alveolar dead space. So by and large, this is just the brief summary of on how to attempt the questions. Thank you. I will welcome contributions and comments.
Okay, thank you so much, Dr. Sani, for taking your part. This looks more like a long thing, but okay, anyway. All right, so I didn't really get the invasive way of measuring oxygen level. You said we have the non-invasive and invasive. So for the non-invasive, you said that's where we actually have the pulse oximeter. We have the transcutaneous, is it venous monitoring?
Oxygen
venous monitoring. Okay, then the mixed, what did you say there? Sorry, I didn't get you. You said something about mixed venous. Something about mixed.
They said the non-invasive one. What was it again?
Near infrared spectrometry.
Dr. Sani, you're distant. You're distant.
Hello, can you hear me?
Okay, say it again. Sorry.
Can you hear me now?
Yeah, I can hear you.
Can you hear me?
I can hear you.
So I mentioned also oximetry, transcutaneous oxygen monitoring, and then near infrared spectrometry. It's a form of they use infrared. So then the invasive, I mentioned arterial blood gas, and then mixed venous oxygen saturation. Hello?
Yeah, okay. I got you.
Mm.
I got you. Thank you.
The mixed venous oxygen saturation is from right heart catheterization.
Yes.
Please, doctor, sorry. The dead space, is there a way you can explain it in simple terms, please? I didn't really get it shortly. The alveolar and is it physiological, please?
Okay. Dead space is dead space has to do with the volume of air that does not participate in gas exchange. You understand? So there is anatomical dead space, there is alveolar dead space. So in anatomical dead space, these are the parts of the respiratory tract that does not participate in gaseous exchange. So we know that gas exchange happens at the alveolar level. So the air in the trachea, the bronchioles and the bronchioles are the ones that constitute the anatomical dead space. Then alveolar dead space. Alveolar dead space has to do with any condition that will affect the that will cause ventilation palpitation mismatch. You know, the ventilation, the gas exchange happened at the alveolar level. So what is been said that ordinarily in normal individuals, the alveolar dead space is negligible. However, certain conditions that will cause either destruction of the alveoli or that will impair, that will cause a gas exchange, will increase the alveolar dead space. So conditions like emphysema, because of the dilatation and destruction of the alveoli, some of the alveoli may not participate, will not be participate in the gaseous exchange. You understand? And then conditions like acute respiratory distress syndrome because of the alveolar damage. And then, so these are the conditions. And then if there is hypoperfusion, hypoperfusion either from shock or if there is a pulmonary embolism. So these are the conditions. So the dead space, so the physiologic dead space is a combination of the alveolar dead space and the anatomic dead space. Like I said, the anatomic dead space is constant because this is the normal anatomy. You understand? These are structures that we know that they are devoid of alveoli and the air there does not participate in the gaseous exchange. So I don't know if that makes it clear.
Yes, much better. Thank you so much.
Okay, do we have any more questions from the participants? All right, so I'll move over to, okay, so in the chat room, Dr. Ojo said that factors that can shift oxygen hemoglobin dissociation to the right, that is more oxygen deposition to the tissues, has got to do with, there's a mnemonic called CADET, high carbon dioxide, acidosis, high 2,3 DPG, exercise, and then and high temperature. Okay, so he said that the cadet mnemonic is actually what we use to, these are the factors that shift oxygen hemoglobin dissociation to the right. So high CO2, acidosis, high 2,3 DPG, exercise, and also high temperature. All right, thank you. So for the non-invasive method of measuring oxygen level, like what Dr. Sambo just posted here, we have the pulse oximetry, the transcutaneous oxygen monitoring, near infrared spectroscopy, and then for the invasive, we have mixed venous oxygen saturation and then arterial blood gas. Thank you. So I don't know if you have any more contributions as regards his presentation. Okay, so in the absence of that, move over to our Chief Orimolade.
Thank you, Dr. Florence. Sorry, I was in and out during his presentation, but I heard the early part and I heard some of the contributions too, and I think it's quite fine. We're okay. I don't. We should just know the various ways by which we can get how would I put this now? Oxygen. We can get perfusion, yes, of the body system. I think that would be important for the purpose of exams and the various how do they call this thing? Pathophysiology of hypoxemia. The ones of all these shunt, ventilation perfusion, mismatch. There are like 5 now. There are like 5 mechanisms of, I can't remember the 5 now. Sorry about that. There are 5 mechanisms of hypoxemia. So we should check that off and add it to what we have presented to be good in case the question comes in another way. And it will also help us to like answer some questions before we get to that pathologic or the death space that we're talking about. So by and large, it's more or less like a general medicine question, like you said. As cardiologists, they expect us to know perfusion and the like. So well done. Thank you.
All right, thank you. So in the absence of further contributions and questions, move over to the next question. Again, I'm supposed to be the one to take that. Okay, so the question says, what is the role of a cardiologist in an open heart surgery team? Okay, so first and foremost, what is an open heart surgery? So an open heart surgery is actually a surgical repair of the heart disorders that is said to involve stenotomy, and may or may not require cardiopulmonary bypass on pump or off pump. So we have indications for open heart surgery. So the indications for open heart surgery are coronary artery bypass grafts, valvular or large artery surgeries, and then also we have congenital defection, defect correction. So when we have congenital defects that we want to do correction, so the best way to approach it is through the open heart surgery. Also device implantation and then heart transplantation. So these are indications for open heart surgery. So we basically have, aside the cardiologists, we actually have other disciplinaries that are involved in open heart surgery. So we have the cardiologists and specifically the interventional cardiologists. Also, we have the surgeons, the cardiothoracic surgeons, that's those ones that are involved with adult congenital heart diseases. Then we have the nurses. The nurses are specifically the cardiac nurses, the theater nurses, the ICU nurses, and then sometimes the ward nurses when they are kind of stable after the surgery. Then the cardiac anesthetists, the intensivists, and then the cardiac physiologists, the perfusionists, psychologists, pharmacists, and then the technicians. So these are people that are actually involved in an open heart surgery. So now going over to the role of a cardiologist in an open heart surgery. So the cardiologist basically what does is that they evaluate, they collaborate with the surgical team to optimize the patient's condition and also to provide a comprehensive post-operative care to ensure that they have the best outcome for the patients. So the cardiologist actually plays several roles. So number one, I'm going to list the roles the cardiologists play, and then I'll go specifically to what exactly they do. So number one, they help in evaluating and making diagnosis of the condition. Then secondly, they play a role in giving a comprehensive preoperative assessment in these patients. Then there's also a role of collaborating with the surgeons. And then they also manage comorbidities, and they also do what's intraoperative monitoring for these patients. They also play a role in the post-operative care, the long-term follow-up, and then also the patient education and support system. So they play a role in all of these things. So they actually help to evaluate and make diagnosis of this patient by using various diagnostic tests like the echogram, the echocardiogram, by doing a stress test, by doing a cardiac catheterization. And then also they help to evaluate the overall cardiovascular health and then determine if this patient would need the surgery. So like that condition we had where they said the patient had an aortic aneurysm, it's actually the role of the cardiologist to make that diagnosis. Then they can now call on the cardiac, the thoracic surgeons or the surgeons specifically for the heart or whatever, the vessels, to come in and then take care of that. So that is the role of the cardiologist, to evaluate and make diagnosis by using their tools to make the diagnosis. Then secondly, they actually do what they make comprehensive preoperative assessment, and how they actually do that is by making getting the patient's medical history. That's where the history comes out, and that's where the physical examination comes out. So they perform physical examination on this patient, and then they also review the imaging studies of this patient to be sure that this patient is fit for surgery. Then also they kind of optimize the patient's medical treatment to help to minimize the risks during the procedure. So the preoperative assessment they basically do is what they get a comprehensive medical history from these patients. They perform physical examination for them, and then they review the investigations to be sure these patients are fit for the surgery, and then they optimize their medical treatment to make sure they don't have any form of arrest during the surgery. Then thirdly, they collaborate with the surgeon. So basically the cardiologists work closely with the cardiac surgeons, and what they basically do is to make sure that the surgical plan comes out successfully. Then they also provide insights into like specifics of the patient's heart condition, and also control, or what they do, they also contribute to the surgical strategy in this patient. So that's basically what they do. They work hand in hand with the surgeons to make sure that the outcome of this patient goes well following the surgery. Then also the cardiologist plays a role in managing the comorbidities of these patients. That's why it's very important to get a medical history from these patients. So if the patient, most times, patients who actually undergo these open heart surgeries have background hypertension, they have background DM, they have background chronic lung diseases. So it's the role of the cardiologist to actually manage these comorbidities in these patients. And then the cardiologist plays a vital role in managing these conditions during and also after the surgery. So they don't just dump the patients after the surgery. So they follow up on the patients during, intra-op, and then post-op of this patient. So that's basically what they do in playing the role of managing the comorbidities. Then also intra-op, the cardiologists also play a role. So what they basically do is that they actually monitor the patients during the surgery. When they're trying to perform the surgery, they basically assess to check if the patient's heart function during the surgery is stable enough, making sure that the patient has a stable circulation during the surgery. Then post-operatively, what they do, they actually play a role in the post-operative care. So after the surgery, the cardiologists are involved in the patient's recovery. They also help to manage the complications that may arise following the surgery. And they also they monitor the heart function throughout their follow-up visits in these patients. And what they also do again after the surgery is that they try to adjust their medications so that it can also help them to it can guide their rehabilitation efforts. Like, for example, there are some surgical procedures that they have to avoid, maybe anticoagulants for a certain time, and then after some certain time, they are placed back on the medication. So soon after the surgery, they're supposed to be placed on certain medications. So basically, what the cardiologist does is that they adjust their medications to make sure that they come out with a better outcome following the surgery. Then also, the cardiologist plays a role. They have a role to play in the aspect of the long-term follow-up, not just leaving them. You have to follow up on this patient because we can actually have complications that can occur several months or years thereafter. So at this point in time, in the long-term follow-up, the cardiologist actually provides a follow-up care to monitor the patient's recovery and then to manage their long-term medication regimens and also to guide their rehabilitation programs and then tailor it towards their individual needs. So that's basically what they do. So they still monitor them thereafter to make sure that their drugs are actually they adhere to their medications, and also they monitor them 6 monthly or yearly to make sure that no complication will actually arise following the open heart surgery. Then lastly, they are kind of involved in the patient's education and then support. So how they actually play a role in this aspect is that they provide education and support for the patients and their families regarding the procedure, regarding the recovery, regarding the lifestyle changes, because there are some certain conditions that they have to actually, like for example, patients who have had a PCI or patients who have had a cabbage done, we have to actually talk to them about not going back to tobacco, maybe reducing their salt intake, their fatty foods, and also basically in this aspect of the patient's education and support, the cardiologists should play a role in their lifestyle changes and also in their long-term management to ensure that they have the best possible outcome. So in summary, the cardiologist plays a multifaceted role in open heart surgery, contributing to various stages of care to ensure that the patient's safety and then the patient has a good safety and then the surgical outcome is being optimized in them. So that's basically what the cardiologist does following an open heart surgery. Thank you. So the room is open to questions and contributions. Any questions or contributions?
Hello?
Yeah, hello, yeah.
Yes, also, just a brief addition. Another role that the cardiologist can play in intra-op, especially for some valvular procedures where they close the shunt, before they close up, after they've gotten the patient off bypass, they can do transesophageal echo to ensure that the procedure had worked so that the shunt has closed completely. There is no residual leak. If it was a shunt, there is a valve that was replaced. There is no leaking of the valve. The valve is in place correctly. And then before they now close the sternotomy. That's also something so to ensure that the procedure was successful before they close the wound.
All right, thank you. So do we have more contributions or questions? All right, so move over to our Chief Chiferimolade.
Yes, then thank you, Dr. Florence. Thank you, Dr. Conte, for that contribution. So, the role of cardiology in open heart surgery. We should not forget the assessment before the operation itself. You talked about it, right?
Yes. The
Prior to the
preoperative
surgery.
assessment.
Yeah, so
Preoperative.
don't just say it as preoperative assessment. Say it as okay, if you're going for a heart surgery now, probably okay, if the patient is going for maybe a valve repair, and or maybe is going for, let me say, coronary artery bypass graft now, and also have some valvular problem or some tiny VSD or ESD that can be corrected simultaneously. Do you get? Or a patient that maybe you want to replace maybe has aortic root problem. So if you have concurrent, it will affect for other concurrent surgical need of the patient, cardiovascular surgical need of the patient prior to surgery. Not that a CTS, a surgeon has gone, has corrected the aortic root, you are now coming back and say there's a cleft on the mitral valve. Do you get what we are trying to say? So not
Yeah.
just saying it as assessment, you have to mention specifically the things you are going to do, assessing the patient for further, you understand, cardiovascular or heart issues that will warrant concurrent management during the surgery. You mentioned that other cardiovascular, other things like not necessarily, don't just mention it as pre-op assessment. That's what I'm trying to say. Just say some more specific things. Dr. Conte pointed out that if patient is going for valvular, to know if there's a leak or not. Even before the surgeon goes in for a valve problem, you must tell them what exactly. Is it an MR? Is it a stenosis? You must say specifically what it is. And you must state specifically severity, you understand, measure accurately, either using a transthoracic or transesophageal as the case may be, or using even cardiac CT or MRI as the case may be, to be able to assess properly and give the surgeon the size of the device here that they want to actually use. So those are the parts of the things that they expect the cardiologist should be able to do before they go in for surgery. And so that is also important. Then the pre-op, not only just I say you must take care of some, depending on the type of surgery that wants to be done. If blood pressure has to be at so rate, it will be the cardiologist that will do. If the heart rate has to be at so rate, the cardiologist will do all those ones. So not just assessment. So you just measure based on the surgery that they want to do. And again, you should mention also that the cardiology will be part of the let me say, you talk about the management or the multidisciplinary team that will be set up prior to the surgery in itself. No, we talked about it like 2 or 3 days ago. So we must look for a way to bring that to in as we start. So having been part of the early team set up with the hospital management and all those things, taking the requirements and everything that will be needed, you go on to do the assessment you talked about and you keep in all those things that we have talked about, then you know that if it's an open heart surgery, a lot of complications can occur, which are most cardiovascular. It's possible you finish a surgery and the heart does not
come on. We talked about arrest on the table today. We talked about ventricular tachycardia during surgery. We talked about all those things. So they must see you just talking about it specifically, that these are the things you anticipate and these are the reasons that how you are going to use them. Your emergency tray and all those things that we talked about 2 or 3 days ago, you should also be able to mention it here. So thank you so much for the discussion.
Sorry, just a quick one. And then I think the cardiologist also helps to rate, stratify the patient. Say, okay, this is a low risk, high risk, and then if it's a low risk,
Yes.
take out.
Yeah, exactly. All those things we talked about 2 days ago. Just didn't want to start repeating it again.
Okay, so I'm supposed to talk about each cardiac condition, and I don't get, like, if it is a heart transplant, I'm supposed to mention this is that. I don't
You
get,
said
sorry,
an
Chief.
open heart surgery. Yeah, because they mentioned that an open heart surgery. In an open heart surgery, you envisage pre, intra, and post. Just the way we talked. Yeah. So we were saying it that day that they can ask about this cardiac surgery in so many ways. They can ask about it in so many ways. If you look at it closely, what we discussed like 2 days ago now is similar to what we are discussing now. In fact,
Yeah.
when you were about starting, I was going to say that do we even have to discuss it again? But I now saw that the way they asked the question, you already think is different from what we have talked about before. So it's not really different. That's what we are trying to say. You can, even today now, we mentioned something about arrhythmias on the table. You understand, malignant this one, COVID, something on the table. Is asking the same question in the same way, or in a different way rather. So you just have to look for a way to make sure that you encompass everything you know about cardiac surgery. Of course, they know you won't be the one to carry out the surgery. So I would just say that when they ask anything about cardiac surgery, just think from a multidisciplinary approach, that you must be part of this one. When you involve the management, you involve the blah blah blah. The surgeon or the cardiologist can be the head of the stream. That's what we are trying to say. So if you are the head of the team now, you still be the one to call the multidisciplinary to make sure that lives and everything. You will now go the way they ask it now. You won't go into saying and you want to do this one. Just say you'll be part of the multidisciplinary where decisions will be made as to foreseeing the complications that can occur pre, intra, and post. Do you get? That's the way you will take. If they take, like, how will you do your transosophageal? If you want to check for your valve disease, all those things are intertwined. That's what we are trying to say. So you must just look for a way to show them that you have a scope of the things that a cardiologist can do during surgical procedures with the CPFC. That's what we are saying. So don't really limit yourself. So you just take it pre, intra, and post. That's what we are trying to say. Do you get it?
Yeah,
So
I
all
get
those
you.
risk assessments, all those risk assessments you will still do. Because what the surgeons need a physician for is to make sure that the patient they are taking for surgery will not die on the table, or they will not have issues after the surgery. So it's the same thing. So all those risks and everything we talked about 2 days ago, you must bring it in a way. Thank you.
Thanks. All right, so in the absence of further questions and contributions, we'll call it a day, and then we'll meet again tomorrow by same time. Thank you, everyone, and good night.